So welcome to our session today, Tales from the Voyage, a fireside chat with a legendary physician, innovator, and educator. Hi, I'm Andrew Cleeland, CEO of Fogarty Innovation, and today I have the true pleasure of talking with Professor Paul Yock. While he needs no introduction, given his stellar career, I'm still going to do it. So Paul is the Martha Meyer Weiland Professor of Medicine and founding co-chair of Stanford's Department of Bioengineering. He is also a founder and director of the Stanford Byers Center for Biodesign. Paul is internationally known for his work inventing, developing, and testing new devices. His inventions have impacted many millions of people around the world. These inventions include the rapid exchange stenting and balloon angioplasty system, which is now the primary system in use worldwide. And he did the foundational work on intravascular ultrasound imaging. Despite the vast impact these inventions have had, I believe Paul's multifaceted legacy will be capped by his influence on the innovators of today and generations well into the future. So welcome, Paul.
Thank you.
All right, let's get into the questions.
Good.
Tell me a little bit about Paul Yock, the young man. Where did you grow up? Did you have a sense early that invention and innovation were going to play such a key role in your future career?
Well, I grew up in a little suburb of Minneapolis called St. Louis Park that some other people made a little bit famous. So Tom Friedman, who's the New York Times columnist, came from there and he wrote about this little suburb. Al Franken was in my year. The Coen brothers made a movie about this little St. Louis, but not Fargo. Another movie.
Another Minnesota.
So, very, Midwest solid, middle class family growing up. And for the second part of the question, no, I was, let me be clear, I was not somebody who knew how to take apart a radio and put it back together, and I was not an expert tinkerer growing up as a kid. The only thing I can relate to is I did like architecture and design, and I was always trying to design things.
Excellent. Sport. What did you do? What was a normal day growing up?
Well, I did the usual things as a kid. In high school, I swam. I was, I think, the only person who was dumb enough to do butterfly and got on the team because of that. And I always finished third. I never finished higher than third in my entire swimming career. But I think when you have to plug like that, that's a good thing. I played soccer too. That was more fun. So we were late to get a soccer team, but I did that and continued that for a year into college. So.
Excellent. That's a good segue into the next question, which is college.
Yeah.
So, and I learned about this quite a while ago, and it's always interested me. So you went to Oxford University's Trinity College to study philosophy.
Yeah.
Philosophy, really?
Well, so I went, before I got to Oxford, I went to a small college called Amherst on the East Coast. And I was pre-med there, but I also thankfully got exposed to other things. And I really liked philosophy. And so I kind of did my chemistry major quick, and my whole last year I just did independent study in philosophy, and I really liked that a lot. Just stimulating, liked the way that the philosophers thought, and I figured I would wind up in medical school ultimately, but I wanted to take some more time to study philosophy, and so I was able to go to Oxford and do it there.
So that's interesting. So it sounds like your heart wanted to do philosophy.
Yeah.
And either your mind, you knew where your future was,
Yeah.
or your parents. What was it?
Well, so there was one pivotal conversation. So I did, when I was a senior, I worked at a place, did an internship at a place called the Institute for Society, Ethics, and the Life Sciences. It was philosophy and life sciences, and the new institute there, and there was a terrific guy who went on to become very prominent, Dan Callahan. And on the last day of that internship, he brought me into the office and sat down and said, what are you going to do with your life? And I said, well, I'm thinking about, I really like philosophy. I like this medical ethics thing. Also, you know, I've done pre-med. I had at that point some early acceptances to medical school. And I said, so I'm kind of weighing those. And he looked at me and he said, go to medical school. and that made sense. I mean, I still have an interest in philosophy, but I'm glad I went to med school.
It's really interesting the impact an internship had on your future career, right? Or the end stage of that, that discussion. Because I think that does start to play out in some of the things you've subsequently gone on to do. Yeah, it's really interesting. All right, in that time though, in that Oxford time, there is a quote that I've read of yours that I love and is also of personal interest to me, given I think my cultural heritage and also my vast experience in things all pub related. The coursework at Oxford was great and educationally challenging, but the level of debate in the pubs was staggering. Come on, you have to explain that. I love that.
Well, it's true. We finish up studying and stuff around 7, and there was a pub literally right under my little apartment where I was in college, and so we go there, and I was blown away by how well-versed, broadly interested, lively the students were in their debates in the pub. And it was the most challenging part of my educational experience there, was just, trying to be part of that, trying to keep up. And I think there is a cultural difference that way, I have to say.
Yeah, well, I mean, I think Oxford attracts folks from all around the world. So, yes, obviously located in the UK, but I'm assuming there would have been a lot of different cultures
There was a
involved
broad group. You're right.
Yeah. I think the one difference between the two of us there, I don't think I would have made it to 7 o'clock before I ended up at the pub. Yeah, it would have been a little bit earlier in the evening. So then you're off to medical school at Harvard. You did residency at UCSF, and then moved on to Stanford.
Mm-hmm.
Really interested, what attracted you to Stanford, and then what has kept you at Stanford all this time?
So probably two separate answers. What attracted me initially was Stanford at that time was really coming up in the field of cardiology, influenced by Dr. Fogarty, Dr. Simpson. Echocardiography was just taking off, and I thought it looked like the place to be for training. Mm-hmm. That turned out to be great. Later on, coming back, and maybe we'll get to this later, but I was up at UCSF for 8 years. Terrific place, great medicine, but I missed the combination of engineering and medicine that Stanford brings together on one campus, and on top of that, the entrepreneurial spirit. I mean, it's kind of a special place.
Yeah, very real, right? Yeah,
Mm-hmm.
Very real. You credit Tom Fogarty and John Simpson as mentors who, quote, changed my life and made it feel, quote, possible to do big things. Can you tell me more about that kind of mentoring you received and why it was so important to you?
I'm glad you asked that question, because I really want to understand why it was that they had such a big impact. So a couple of things, I think. First of all, they are both extraordinary in different ways. Tom Fogarty has a drive for excellence that is just encompasses everything that he does. He has such high standards, and somehow he makes you want to hit those standards. Yeah. I remember when we did the first intravascular ultrasound images in Norway, actually, and I brought back the tape to show to him, and showed him the tape, and it was quiet. And then he said, I can't see bleep in these images.
Constructive feedback.
and I mean, you wanted to be your best for him. There's just something about that. John Simpson has a different flavor to me, and brilliant guy and somebody who you want to be like. But his, I thought, special characteristic was just his determination. That guy has such persistence and such, he does not stop. And I admire that tremendously and wanted to be like that. I'm going to keep going with one other thing because I care about this topic, and that is, there is a way that both of them extract from you, bring something out of you, and I really would like to know how they do that. Part of it is paying attention. They even when I was very, very young, they took me seriously and spent time. But there's something else. There's something kind of catalytic about the way they interact, and you find yourself thinking smarter or
Do they? I think this is really important. So I would, if you don't mind, let's keep exploring this. Do they do it with intent, or they do it instinctively? Right? Are they trying to mentor, or is it just who they are?
It must be a combination of both, right? It is a special skill, and so I don't think they set out to, develop that necessarily, but they both care about mentoring, and so it's a reinforcing behavior.
Yeah, good. I'm just trying to go through. I'm like, mentoring is important to both of us here, and I think as students of the process, it is always interesting to try and understand how they had such an impact on you and on many, many others, right?
Yeah.
And I think the way you described both of them is obviously very accurate. But Dr. Simpson, the term that comes to my mind there is relentless. Right? He has a mission, and he's gonna go after that. And Tom's more entrepreneurial. I mean, they're both entrepreneurs, but mercurial is what I would call Tom. Mercurial.
That's a good one.
Hopefully, Dr. Fogarty, you're not watching this right now.
He'd like that, I think. Yeah.
Mercurial. All right, we can't have this conversation without talking about rapid exchange and IVUS. Can you tell us the stories there?
So let's start with IVUS. This goes back to Dr. Simpson, who I did a angioplasty fellowship with him before there was an angioplasty fellowship, but I trained with him, and one morning he came in and sat down in a little conference room, had a briefcase, opened it up, took a catheter out, and said, "This is what I'm working on. This is an atherectomy catheter, and here's the way it's going to work. You see this thing, it's going to cut on the side of the tip of the catheter. We'll put it into the blockage and we'll cut around the clock." So that week I was studying for my boards in cardiology and had just come across the fact that plaque usually exists on one side of an artery, that it builds up on one side, even to severe stages. So I was sitting there thinking, Houston, we have a problem, which is, I'm fine with you cutting on the plaque side of the artery.
Yep, not the other side.
But not the other side. And started thinking about, okay, how can we guide that cutting? Because an angiogram won't do it.
Yep.
And I had trained in ultrasound at Stanford and thought, well, maybe it's possible to make that transducer tiny enough that we can look inside the artery, and that would tell us where the plaque is all the way around.
So that's invention, right? Yeah, a problem that you've had, the solution is there that you've seen.
Yeah.
And it's putting the two together.
Yeah.
Here is the need
Yeah.
with the tool.
Yeah.
Awesome. And it's really talking about relentless, right? That was, I'm guessing that was a little while ago.
Yeah.
Or I know that was a little while ago.
Yeah.
That John is still working on
Yeah.
those
Yeah.
systems today.
Yeah, that's right.
Keep continuing to improve
The
them.
guidance, yeah. And then
Rapid exchange, yeah.
rapid exchange. So also partly having to do with John and the other people doing procedures. So with the original catheter system, the over-the-wire system, there were two operators to do the procedure. There was the senior operator who was moving the catheter up and down, and then there was a flunky who was sitting down by the patient's feet, actually, and the job for the flunky was to keep the guide wire in position in the heart while the honcho moved the catheter up and down. So there was a flaw in that system, which is the honcho would often forget to tell the flunky that he was about to jerk the catheter out of the heart, right?
Yep.
When that happened, it was the flunky's fault.
Of course.
And it just was a kind of a crazy system, right? That you could allow that to happen. So not a huge Socratic leap to say, wait a minute, there's got to be a better way of doing this.
Yep.
So I started working on different ways and slicing and dicing catheters and ultimately came up with rapid exchange.
And how did you end up, so from the concept, how do we get concept to a product that is dominant in the market today? How'd that happen?
Well, there too, first of all, John pointed me to a patent attorney, and so got it patented. And then at the time, ACS was emerging as a really important angioplasty company, and they were really good at guide wires, and wanted to have a really good guide wire. So it made sense to present this to ACS. And so I had a prototype built, and I went in to see Carl Simpson, who at the time was head of R&D. He's passed away subsequently. And I remember this very vividly. So he had a heart model on a little coffee table, and he said, "Okay, show me what you got." And I said, "Well, this is a system that allows one operator to do angioplasty. You don't have to have two operators." And that kind of got his curiosity going.
I bet it got his attention. Yeah.
And so he said, "Okay, show me how it works." And so I set it up and did an angioplasty on this model by myself, kind of, and this. You can move the catheters kind of quickly with rapid exchange, and so
hence the name.
Yeah. So I did a case on this little plastic heart, and he sat there for a second and said, "Holy shit!" And he ran out of the room, and he came back with Gary Curtis, who was the head of sales, and he said, "Look at this thing," and so I did it again. And Curtis was much less emotional, and he kind of looked at it and he said, "I can sell that." And that was the start of getting it licensed to ACS and taking it forward.
But that's also, again, that's the interrelationship, right? You got an invention, an idea, but to truly get it to market, you need others to help, right?
Absolutely.
It's not a physician inventor. There's obviously a huge team.
Yeah.
But just that interaction, I think the difference between the two of them, one's running engineering, loves the idea. The other guy knows he's going to have to negotiate with you eventually. So I bet you he was just as excited, but he was trying to pretend not to be.
Yeah.
All right. Yeah. So that led to the impact has been on millions and millions of people around the world. So both of those inventions. I know you've got a few others, but I want to talk about another big invention of yours, along with a couple other folks. But Biodesign.
Yeah.
You know, why? Tell me a little bit about the founding of Biodesign and its concept.
Yeah. So, by what we've talked about already, it's pretty clear. I was incredibly lucky, right time, right place, to get mentoring from John Simpson, from Tom Fogarty, and.
So I do want to say, I got to interrupt there. Correct. Right time, right place. But you've also got to be the right person to be able to take advantage of that.
I'm not sure I'm going to agree with that.
Sorry to interrupt.
And so, watching what they did for me, it was clear that could be structured. That this is my Australian salute here with the flies.
With the flies.
That it made sense to do some of that in the context of the university. There's so much, not only for students but faculty, so much inventing that's wasted. That because there's not a need for it, or you don't know exactly how to take it forward, and there's no reason that you know that. You're not. Few people are born with that skill, I guess, like Tom and John, but the rest of us aren't.
Yep.
And so there's a set of techniques and actually kind of a discipline that could be taught. And coming back to Stanford, it was absolutely the right place to do it. To not only with people there, but to be able to take shameless advantage of people like you in the environment who can help teach and mentor. So that was kind of the origin of biodesign.
Yeah, excellent. And again, the interesting thing is yourself, Tom, and Dr. Simpson. They're individuals, and so taking those skills and then trying to put it into a coursework.
Mm-hmm.
That has got to have been difficult. How successful do you think you've been?
It's a mixed accomplishment, right? So I do think that there is a repeatable process that can be taught and learned and practiced and perfected that increases your odds of success. I do really believe that, and we have a track record now of first-time trainees who've done well.
Absolutely.
So I do believe that. I do think, though, that where we fall short is understandable that the environment changes very fast.
Yeah.
And so you really have to constantly have people mentoring who understand
The current environment.
The current environment. That's exactly right.
Yeah. Well, one element of the biodesign process that I believe to my core is the needs assessment, the needs, understanding the need. Can you talk through that? Because regardless of the environment, that is a core underpinning of this whole program.
Yeah. Well, I guess I'd start with the point that there is a lot of great, what I call technology push innovation, where you have a brilliant invention and then you figure out where that gets applied. That's great. That has to continue to go on, both in companies and universities. But especially in our sector of health technology, you can look at the inverse of that. That is, to start with the understanding of a need, really go deep on that understanding, and then figure out what mix of technologies can be brought to bear on that need. Mm-hmm. And it works especially well, I think, in health technology for a couple of reasons. One is our landscape of important stakeholders is really complicated. It's not like inventing a consumer technology where you have one customer, and if you understand that customer profile, you're off to the races. Right? It would be great if you could just invent for the patient or the patient and physician.
Yep.
But we have this weird system where they're not purchasing the technology, right? The hospital is, or the insurance companies are. Somebody else is regulating the technology, and that's a huge stakeholder, right? And then, we have to be careful of the press. We have business entities. We have physician groups that could block a new innovation. It depends on the government in a heavy way, and all of the stakeholders shift their priorities when something like Obamacare comes up or whatever we're doing now comes up. So it's complicated.
Yeah, your image of a many-headed hydra. I stole that the other day for a presentation with FDA. All right, so next year is Biodesign's 20th,
Yeah.
20th anniversary.
Yeah.
What are you most proud of? I think from my perspective, that program has been incredibly influential and will continue to be for, for decades to come, because you've spawned processes, not just a way of thinking, but the other collaborative programs around the world. So what are you most proud of?
I think easy answer actually. I'm most proud of the trainees of the program. I mean, we have some just incredibly talented young people. We have 30 CEOs of companies now that came through the program. And on the flip side, a bunch of people on faculties of major universities, both in engineering and medicine, 10 at Stanford alone. And they all understand this process.
Yeah, the methodology.
Yep.
Yeah. And that's what you're most proud of.
Absolutely.
It is that the output of this program is people.
Yeah, hands down.
And I think this does go back to the point that you made a long time ago. Your internship, the impact that had on you. It's through people that these things live, right, and grow. And I think that well, we're living through a pandemic right now, right?
Yeah.
It's your version of a pandemic, in the nice way.
Yeah, exactly.
So, moving on a little bit, so we touched on what we were calling the traditional biodesign. You're using the biodesign method in other areas now, in areas of diversity, equity, quality. Would you like to talk a little bit about that?
Well, I guess that the linkage is, I think the process works well in any situation where there's a really complicated set of stakeholders and where you really want to slow yourself down before trying to find solutions. Slow yourself down and deeply understand what is the nature of the need. And there's no more complicated scenario, I think, than these issues of diversity and inequity in healthcare. And so we are trying to work with some different groups to look at gender issues, to look at racial issues, to look at health inequity issues in general using this methodology and explicitly being really careful and methodical about saying what are the most important needs that we need to solve before doing a ready, fire, aim innovation.
Yeah, which is I could not agree more, right? And I think you're talking about numbers of areas that are incredibly complex.
Yeah.
And simple answers, while we would all like to be able to have simple answers, they can be quite dangerous. So yeah.
And where our instincts don't work.
Yeah.
So.
Excellent. What's next for Stanford Biodesign? This is a quick layup question for you.
Yeah.
What's next for Biodesign?
I have this partnership with a crazy Australian. So one of the things that we haven't done from the university perspective, one of the things that we have not done well is the next step beyond a good invention. We're good at characterizing needs, we're good at getting to an invention of some sort, and then we've said, good luck, go make it happen. When we started 20 years ago, there was enough money in the system, and the Valley could absorb a good idea and make something out of it.
Give it enough time.
Exactly right.
Yeah.
Not true anymore.
Yeah.
So I think we need to put additional resources into that important next stage, preparing people, really shaping up that project so that it is business ready, that it can attract some funding, and getting a team together that has the ability to take it forward. So that's an important next step, and our partnership with Fogarty Innovation is, I'm just delighted to that is the missing piece. I mean, it's nice to have prototyping space and so on. That's great. The important piece is the expertise.
I was going to say, it gets back to the people again, right?
Exactly.
Right. Everything in my career comes back to team, to people. Yeah.
Yep.
No, so thank you. And that was a definite layup for that question. All right, so we all know that health technology innovation is tough. We spoke about the many-headed hydra before. In fact, you've been known to say cool inventions aren't cool unless they make it into patient care. What are the biggest challenges today that you see?
Mm-hmm. So I guess I'd say two layers of challenge. One is just purely from a business lens, no question, getting enough initial reimbursement for a new technology to get legs to be able to prove itself is the major obstacle. At a higher level, though, I think COVID is making us aware of the fact that we really have a bad inequity situation going on with how we deliver products, health products, to patients.
Mm-hmm.
And, I think we have to be aware of the fact that a lot of the technology that we invent does go to that upper tier of patients. And so I worry about that.
So I wonder, though, if I totally agree and totally understand, but that's also where the payment is.
Yeah.
And so, this is a structural thing we'd have to have a look at to be able to do that, right? Because you're not going to, there needs to be the incentive, right?
Yeah, you can't invent your way out of that problem.
No, you need to change the system.
Yeah.
Look, the breakthrough technology that FDA's had for a while that now CMS is leveraging, that's going to be very interesting over the coming years to see how that works, and maybe that becomes a pilot. So you touched on COVID, the question earlier that I was coming to, that it'd be remiss of us not to talk about the impact that COVID has had, and I don't mean this year, I mean for the future.
Yeah.
How do you see lasting impact here?
Yeah. Well, I will pick up again on, a silver lining is that it has made us all aware of health inequity, distribution of healthcare in the country. So that's hugely important. There's also, though, I think an interesting amplification of something that was going on anyway, which is a shift to consumer focus in health care and health technology. And now with telehealth, with home visits, we are wholesale looking at the whole enterprise of how healthcare gets delivered. And I think it's going to increase the shift to home-based. How can we do consumer-facing? But that means being able to access healthcare from your home in a more user-friendly, more comfortable, more effective way. And there's a heap of innovation that can happen in that sector.
Yeah, I really hope that folks look for real problems, though, right? So I think that the drive to treat, that was almost a deliberate misstep in what I was saying. We need to be looking at treating patients in the home, not just monitoring.
Yes.
Right. So the whole concept of looking at our hospital infrastructure and saying, hey, there might be a bit of a flaw there. How do we move therapy? So diagnosis, monitoring, and therapy to home.
Yeah.
I like the original surge of digital health.
Yes.
Right. I think they were targeted in the wrong area. They were consumer-oriented products that really weren't healthcare products.
Yeah.
And so I think it's just going to be interesting. What do you think about that? Is that?
Well, the other thing it makes me think about is how to put this together. So one of the big levers that consumer technologies have is their ability to influence behavior. I'm thinking about, Facebook and Google and Apple and so on. And here again with COVID, we've seen how incredibly important behavior is to health.
Yep.
I mean, if we could change one thing right now to impact the virus, it would be behavior.
Yeah, mask wearing.
Right.
Yeah.
So that's maybe another direction that comes out of all of this.
Yeah, I think I've heard Peter Fitz talk about this concept, and you know, all your career, all of my career has been treating, quite frankly, chronic
Yes.
disease,
Yeah.
late stage disease.
Yeah.
The only way to change that course, honestly, is change behavior.
Yes.
So to be a little bit more preventive.
Yes.
We can't do that with a stent. We can't do that with a mitral valve. We need to be doing it with another tool, and that's where the digital tools
Yeah.
can really
Yeah.
come
That's
in.
exactly right.
Yeah. Yeah, maybe that's, yeah. I mean, I know that's why both of our programs are heavily looking into this space. I just want us to be really careful,
Yeah.
right? I don't want it to be the next shiny object.
Right.
Right? We need to think carefully. We need to apply the Biodesign
Yeah.
method to this.
Yeah.
All right, so to finish up, I've got 4 more questions. A little bit more fun.
Okay.
What's next for you? What's next? What's the next part of your career?
So career-wise, I mean, I do genuinely want to focus on this problem of helping people not fall off the cliff. You know, I've got a good invention, but what's next?
Yep.
So I want to put some energy into that. I also pick up another thing we've talked about. I want to continue to work in biodesign. I do want to genuinely work on our diversity. Our field is terrible. I thought as recently as a couple years ago that health tech must be better than regular tech in terms of gender diversity and racial ethnic diversity. Not true. It is, I'd make the case it's more important for us to be diverse in health tech because we're trying to serve those patients, right?
Yeah.
And so why are we not doing it? So I'd like to put some energy into that.
Well, that's a big task, and it's it is the right task that we should be doing.
Yeah.
Yeah, a noble task. You've been incredibly successful. You've accomplished a tremendous amount, not just now, right? The folks that you've educated are going to go on for a long, long time here and propagating. What about you?
Yeah. So a couple of things. I want to take a little bit of time and do some needs finding in a particular area. I have a general sense that there's a leverage point somewhere in K-12 with respect to underserved students, and I don't understand this area very well, and I don't want to go too far on my instincts, but I want to learn more about what the situation is with respect to those kids and what we might be able to do to leverage that better.
Awesome.
So
let me know how I can help.
yeah.
Yeah,
Well,
seriously.
We'll see. I think it's an incredibly highly amplified point to focus on.
Yeah, I think what got to me in that was your leverage point, right?
Yeah.
There's an opportunity to have a multiplier effect
Yeah,
early.
exactly right. Yeah.
Thinking back over your entire career, what would you have done differently? Okay, not going all the way back to philosophy and maybe continuing that
Yeah.
because the world's a better place that you didn't choose to do that. What would you have done differently?
I find that hard to answer, actually.
Yeah. That's why I asked.
Yeah. So I think the reason it's hard to answer is that I feel incredibly lucky, career-wise. I am a walking, talking example, right time, right place, along the way. And so I can't, that just was so extraordinary that I can't kind of think
Yeah.
about rewriting any of that. I will. I don't.
So a good answer is nothing.
Yeah.
That's okay.
All right. Thank
Yeah,
you.
yeah.
I'll stick with
leave you
that.
at that. Yeah, because I think it's true.
Yeah.
Two more.
Fire away.
What's one thing that we don't know about Paul Yock?
Oh, that's another. This is where I'm supposed to, like, yodel or have a llama collection or something like that, right?
What is the what are the
So,
the folks in your professional
so
sphere?
I have a really boring answer to that, which is I still read a lot of philosophy and religion, and I'm really fascinated by what different people think and believe and why they believe that. So that's kind of a big hobby for me.
Have you got the opportunity to take time at Stanford? I mean, I'm pretty. Do they do philosophy at Stanford?
Oh yeah, absolutely.
Sorry.
So no, and I do hope that I'm going to downshift a little bit in terms of work hours in what I have been doing. That's exactly the direction I want to go.
Beautiful. That'd be coming full circle.
Yeah.
And I will join you in the pubs to have discussions. You can teach me.
What the guy I told you who gave me the advice not to do philosophy but to go to med school, he said, when you're in your gentle years, then you can come back to philosophy. And so I figure I'm getting there.
Yeah, you're not in your gentle years yet. All right, finish up. What's one, for the young folks out there, what's one piece of advice you'd give them today?
Yeah, so all of the usual advice is right? Don't sit around, go try it, figure out what you don't know how to do and build a team around that. Don't stop, just keep pushing. All of those are really big things. The one I'd want to add that sort of flows from our discussion is finding a mentor doesn't happen. It's you have to go out and do it, and it is critically important. And you have to shop your mentors, and you want to pick based on experience, of course, but you want to pick somebody where character is on the docket, as they're saying. Pick somebody who's honest, who really is going to look out for you, but has good values, and spend a lot of time shopping to find that mentor.
Yeah, I think that is excellent advice, because we talk about mentorship, we all do, the value of it, but I do feel that sometimes people expect to be mentored.
Yes.
Rather than seeking it out.
Yes, exactly right.
And I think you've got to seek it, and again, character is more than on the docket. Character is it.
Yeah.
So thank you. Really appreciate you taking
you.
your time today. Looking forward to doing this many more times into the future.
All right. Sounds good to me.
Particularly as we move into your gentle years with the philosophy. I want to get into that. So thanks, Paul.
You're welcome.
Thanks
Thank you,
everybody.